Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians. Practice medicine the way you've always wanted. Data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Welcome to Working Smarter, Medical Malpractice Trends and Best Practices. This is a little pre-intro because Dr. Torontow and I got a little carried away, and it's now two parts. We recorded it all as one, but this is part one of our conversation on medical malpractice trends and best practices. Welcome to this session of Working Smarter. This is medical malpractice trends and best practices. The speakers on this podcast today are Kelley Smits. I'm the Vice President of Risk Management, and
Oh, hi. Good morning. I'm Dr. John Torontow. I'm the EVP and National Medical Director, and I'm really happy to be here, especially working with the newly minted Vice President of Risk Management.
thank you,
Congrats.
Torontow. Thank you. So we're going to kind of give you guys a nice snapshot today and go through the trends and best practices for medical malpractice, which, is always top of mind for clinicians. So we're going to kind of go over the trends in primary care. We have a data snapshot over all disciplines, but we also do kind of a deeper dive into family medicine, just because we're a focused primary care company. And then we have a couple case studies to go over, and then just kind of summing up best practices that we want, all of our providers to keep in mind. And then contact information and how, to reach out to us and how to make sure that you're engaged in making this company better and, decreasing our medical malpractice risk as a whole at Village. The information that we're going to dive into, the case studies and the claims data that we've received, it's all from MedPro. MedPro, they studied thousands and thousands of claims over years and years to come up with this data. So it's really helpful to have a snapshot like this. And a lot of the information is going to be intuitive and you're going to understand it, but there might be some pieces that you might not have thought of or maybe surprising. So that's why we thought it would be worth diving into this and just sharing this data with you. So we're gonna peek into all disciplines first and just kind of give you the headlines there. For claims data, diagnosis related is the top in terms of liability, severity, and cost. I don't think anyone is surprised by that. Making diagnoses in primary care is, one of the main things that we do as a company. So it's very important. And, it goes without saying, primary care, the two most common claims are failure to diagnose or failure to treat a diagnosis. So, the fact that diagnosis related claims are the highest number of claims isn't surprising. Dr. Torontow, any thoughts or comments on this slide?
No, this is sort of interesting to me because, everyone knows if you practice any medicine and have done any training that, obstetrics is obviously one of the highest risk professions. Surprised that surgical treatment is lower, but, diagnosis related, which is where we live and breathe. I do have a question for you, Kelley, though. So we talk about failure to diagnose and delay to diagnose. Is there a difference between those two things in the legal world?
Question. So failure to diagnose would be not ordering the correct test. So you have a 60-year-old woman who's never had a mammogram and you don't order one. Failure to treat is you get mammogram results that have findings, but you do not act upon them. So you have findings in your EMR, you may have reviewed them, maybe they slipped through the cracks in some way. And so we did not act upon a finding. So that's the failure to treat. So that's the difference between failure to diagnose and failure to treat a diagnosis.
Okay, that's helpful. Thank you.
Of course. This is again across all specialties, but you can see this was kind of surprising to me. My career pre-Village was in hospital healthcare systems, and I'm very surprised to see that claims are moving towards ambulatory. Now, it makes sense because the patient population is also moving to ambulatory care. There's less patients going into hospitals. We're trying to handle more things and work with our patients on an outpatient basis. Um, but the claims are lagging behind, but they're starting to follow now. So, you know, the case volume out of an office and a clinic, it's 54%. So over half of ambulatory cases, it's from an office like ours. Um, and then it's moving into, things like radiology and ambulatory surgery. But I was surprised by this slide. Um, primary care historically is one of the lowest litigated, which, makes me happy. But I do see the tide kind of turning and the tide changing that, outpatient care, primary care, there is going to be a time where more and more focus is brought to, plaintiffs attorneys are getting smart and realizing, if we can follow the chain of events further back, then that's where they're going to go. So
Yeah, I think that's a good point. And I think there'd be a lot of clinicians who would look at this slide and say, well, part of the reason that, there's less, say, in the emergency department, right? And certainly in terms of diagnosis related cases is that, that is the milieu where you practice a lot of defensive medicine. You rule everything out possibly. The same thing would be true in inpatient setting, right? Lots of testing to make sure you don't miss anything. And primary care is not really built that way. I think that's partially true. I don't think that we should be, and we're not going to in the course of this talk, really stress the importance of like over testing to practice defensive medicine. Defensive medicine, in my mind, goes a little bit, it's an overkill in some ways. What we will talk about is just following the guidelines and then being diligent about like reviewing your own results that you ordered, right? Some of this is some common sense.
love it. Agree.
Yeah.
Agree wholeheartedly. Okay, one more on the general slide. It has the most common primary responsible service type. So who is determined as primarily the most responsible during a claim? And so surgery top, specialties top, then ortho, but general medicine is tied with ortho. Again, above OBGYN, above emergency medicine, above anesthesiology, general surgery, radiology. This is surprising to me to see general medicine this high. And across the diagnosis related cases specifically, it has those service types called out in green. General medicine is the top. So this is kind of surprising the way, historically claims. I don't think anyone would think, emergency medicine would be below general medicine. So it's just an interesting slide. And again, this is from almost 10 years of data, thousands and thousands of claims. So it's just an interesting point that I wasn't aware of and not where my mind went. So this slide I thought was important to call out.
Yeah, I think I agree with you. It's kind of interesting looking at how, general medicine, which would be, obviously general internal medicine and family medicine that, was where most of our folks practice at VillageMD. So we're not immune to this. And part of that is sort of our, and speak to this, our relationship in a case that rarely is there a malpractice case that happens where everyone involved in the care isn't involved in the claim. And, if you're a primary care doctor, that's sort of where you're on the line. Is that part of what we're seeing here?
Yes. And, one of the things that we'll talk about in a few minutes is, I don't want people to just be scared. So we're going to give you tools and tips and tricks and why we think the Village Care model helps you in terms of litigation risk. So, here's the kind of doom and gloom at the beginning. And we're going to do a little deeper dive into the family medicine piece as well, go over some case studies, but we are going to give you some tips and tricks and thoughts so that you feel, educated and that you have the tools that you need to succeed to mitigate this risk. So now doing a dive into MedPro had family medicine as a call out type. They did not have internal medicine, but I would say a lot of this still applies, regardless, this is, primary care. So I don't think that this would surprise anyone. And this is probably the bulk of those diagnoses, the reason why primary care and general medicine is as high on the list as it is. It all comes down to the diagnosis of cancer. I mean, that is such a big piece, obviously there's cardiac, infection, stroke, I would say that those go without saying as well. We all think of those things, cardiac especially. But cancer is the crux and, the quiet one that can sneak by. Historically at Village, our claims history, I would say the majority have been in this category of claims that we've had. And again, we don't have very many claims at Village, but we don't want cancer claims either. So, Dr. Toronto, I don't know if you have thoughts on the types that they have listed out, and that lung being the highest kind of surprised me. And just make sure that, if you have any thoughts on what we have built into Athena or what we have built into our clinical model to make sure that, providers are all aware of this, or we have, ticklers and processes in place on cancer reminders.
Yeah, that's a great question. I would say if you look at these, lung, colorectal, obviously, and breast, prostate to some extent, all of these can really be solved for with if there were only a visit that we did once a year to sort of make sure everyone was up to date on all of their screenings. And
would that be the annual wellness visit, Dr.
spoiler alert, it's the annual wellness visit. Another really important reason to do an annual wellness visit. We need to verify that we do have, the clinical decision support, driving lung cancer screening as an example, and that we're up to date. But the current guidelines for lung cancer, anyone who's had a 20-pack year history, gets a chest CT, low dose screening chest CT every year until they get to that point where it doesn't really make any sense for their life. So if they get sick and the life expectancy isn't long enough to sort of drive that, or they've quit smoking for at least 15 years. So I think that's probably an underutilized opportunity. That is actually a Medicare benefit and it's paid for. But we can make sure this might be an opportunity for us to get better here. Colorectal cancer screening is actually something we do pretty well on. Always an opportunity to get better, and there's multiple modalities. Obviously, the gold standard is the colonoscopy every 10 years, but there's also Cologuard, which is a FIT plus DNA testing that's an option every 3 years, even a FIT test every year. And they're all clinically, they're all about the same. They're all about the same in terms of their efficacy of detecting tumors and saving lives, and in terms of cost. So a colonoscopy every 10 years, a Cologuard every 3 years, or a FIT test every year, all add up to being equal in terms of their strategy, in terms of their total cost and their ability to save lives. So that's something that maybe not everyone knows about or is aware of. So if you can't talk someone in or get someone into a colonoscopy, it doesn't mean there aren't other ways to continue a screening protocol for that patient. Breast cancer screening is always up for debate. Again, that's the task force. Their last recommendation came out in 2016. It's currently under review. If you go to the American Cancer Society, you'll see something different. But the current task force recommendation is women over the age of 50 getting screened between 50 and 75 every 2 years. And that's our minimum standard. And we actually have standing orders in place for that. So we're actually going behind and making sure that all of our patients in that age category are getting screened at least twice a year if they're again at normal risk. And prostate cancer screening is always a fun debate. There's still people out there doing an annual PSA. It's actually a little more complicated. It really is a shared decision-making process. And it's a good call out for the CME team to probably spend some time building some education material around these four opportunities for learning.
Well, I love the call out on the prostate in terms of shared decision-making and communication. Communication is key, and you'll see some things come across in the next slides specifically around that communication piece. So contributing factors, diagnosis related is, very high for clinical judgment. Communications next, behavior, documentation, clinical systems. Again, I don't think anybody is surprised by anything on here. The next slide does a deep dive into the diagnosis related allegations. And this, I can't understate enough, again, ties to that communication piece. You can see that these specific factors have been identified as, the crux of, the outcome, and they're more expensive claims. Poor communication, 37%, the highest. This is failed communication among providers, critical patient information. So, for example, if you send a patient to a specialist, we have to make sure that we close that loop and that results are communicated back. Now, of course, we would assume the burden is on the person, the specialist that we sent the patient to. But if there's a bad outcome, it's likely that you will be critiqued for not closing that loop. So there are really important things here. Documentation, can't understate that enough. That's second place. Documenting every conversation you have, every phone call you have with the patient. While it's burdensome, it is the best defense. The record and proper documentation of the life cycle and the relationship you have with your patient is really your best defense. Clinical judgment, clinical systems, patient behaviors, of course, all of those tie into it as well. But communication in itself is just critical to healthcare. Primary care, you have the responsibility and the joy of having the closest relationship that most patients have with a provider is usually their primary care provider. So with that, being a good communicator will make all of the difference in the world. I don't know, Dr. Toronto, if you have thoughts on that. I have seen, terrible outcomes where, because the relationship and the communication was so great between the primary and the patient was okay. The patient continued to see the primary, even as after a result of the mistake, just because the communication was so excellent, and that relationship was so important to the patient, and they felt like they were, part of the team between the provider and the patient.
No, I think that can't be understated. The importance of having that relationship and that communication with the patient it can be actually a medical malpractice attorney's worst nightmare, because we've seen them, you and I in our work have seen this happen already within Village. But it's also, lots of cases in the literature where it's clear that the primary care clinician made a mistake, and there was an error in clinical judgment. But when it came to time to bring the case, the patient didn't want to sue because of the relationship they had with that clinician. So and it gets down to like being liked, which is kind of I think that's a gross estimate. I mean, I don't know that that's
Right.
really actually the truth. It's not actually being liked. It's actually having a relationship and communicating well with the patient over time. So it's so important to really, over communicate with your patients, develop that relationship. And that is protective. Now, does that mean you can go around and like be nice and everyone likes you and then be a dope? No, that's not, it doesn't work that way, but it is super important. And I think that the element of that patient provider relationship that is probably common in those cases where a patient didn't want to sue, even though the clinician was probably at fault, is really about that communication. So I think that's super important. I think the other thing that again, from conversations that you and I have every other week, this idea that non-adherent patients are really the problem. It's not the case, right? That's a small number. Clinical judgment is not as important as we think, but again, we have guidelines so that you can follow, so you actually don't make mistakes. So staying up to date on the literature, or following our best practices that we've developed, our clinical model, will keep you out of trouble there. And then documentation, documentation, we also can help you, help our clinicians solve for that. If you're bad at typing or write short notes because it's more expeditious for you to get your work done, we actually have a digital assistant now that people can use, Suki, that would allow them to document in a way that is more rich. And with the current guidelines of medical decision making being, that is where all the documentation lies currently. You don't necessarily have to spend as much time on you should document physical exam findings and review of system questions that you ask, but it's not a box checking exercise like it used to be. But it really is an opportunity for you to really talk through and express what you're actually thinking about. And you should do that openly in your notes in terms of, this is the plan. This is what I think it is. This is my next step and my step after that, depending. And a lot of this happens in our brains, but never ends up in the documentation. So I encourage people to do that more. And again, use some of our tools to make that easier for you. We do have some docs who do some documentation in the room in front of the patient. That is actually probably best practice. It's hard to get people to do that, but actually having a dictating in front of the patient, it makes, again, is a communication piece that also helps the patient understand what's going on. It reinforces that. And then, we need to, and we talk about this all the time, we have to make sure that our clinical systems work. And we are constantly working on that to try to make sure that is sort of almost set in the background, and that things are going out to the patients as fast as possible. And we're not, we're trying to make those systems efficient. Sorry, I interrupted you. You were about to say something, Kelley.
No, I agree with everything you said. And let us, this is an invitation for, if we need your partnership. If there is something with the documentation or the systems, we want you to raise your hand. If you have ideas about how to make something better, we want your ideas. We have committees and groups that, we are going to be in a constant state of improvement to mitigate these risks. But if you have ideas or you're struggling, please raise your hand. You can always contact risk or go up, your chain of command, go to your clinical leadership in your market. But, staying quiet or suffering or knowing that something isn't being done well or could be done better isn't going to help anyone. So I hope that, as a result of this, that providers feel kind of empowered to be part of the solution here and to really raise their hand.
Yeah, absolutely. It's super, super important. Don't suffer in silence. You have, what's the post 9/11, see something, say something.
Say something, yeah.
That still exists today for us. So it's super important.
Agree. And that's where we're going to end it for now for part 1. Please listen to part 2, where we go into case scenarios and actionable items and how to best mitigate all of the trends that we identified in part 1. Thanks.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.